I started recording. Yes. Good. So, red flags and their weightings. So, who knows about flags? I suggest you switch your mic on and your video on, please. Thank you for giving me the thumb up, guys. So, flags. Who wants to step up to the plate and give me an idea of the understanding of flags and what red flags are?
So red flags tend to be like indicators of more serious pathologies.
Okay, good. Flags in general, which flags do you know about?
There's like yellow, blue and red. I think there's another one, but I've forgotten.
Okay, yellow flags. I don't like the terms, but sadly we have to use those. Okay, so you yellow flaggy patient, let's call it like that. What are those?
So more psychological.
Mm-hmm.
Can you look and catastrophizing behaviors, for example?
Yeah. Can yellow flags be red flags?
Yeah, I mean, if you had somebody with serious mental health issues, then it's going to have to be escalated if they're at risk at that point immediately.
Absolutely. Can you think of something in particular?
Well, for example, if they're a suicide risk or they're at risk to others.
Absolutely, or risk to themselves. Absolutely, definitely. Any other flags that you know of?
The blue one, it's for work, I think, like occupational issues.
Yeah, absolutely. And can those blue flags become yellow flags? I think the answer is in the question. Yes, indeed, absolutely. What other flags do you know?
Do you have black ones as well? Is there black flags?
Yeah.
I don't know what they are though.
They're the things around still linked to the workplace, but around litigation aspects and compensation claims. So recently, I had to deal with somebody who had an accident at work. His accident was in April. We're in October. He's not back to full duties. Okay, and the all likelihood is, okay, it's difficult to address those, but the all likelihood is because he's pursuing a claim. And if he is claiming, but if he was back to full duties, in all likelihood, the person being sued could turn around and say, but this gentleman is back to full duties, so the claim level could be lowered. So as a result, he is still not returning to full duties because he still has an ongoing claim. And if he's not on full duties, he can then claim that the accident was so severe that it's affected in the long term. And the proof is, look, I'm not back on full duties. Okay, so that's a big barrier to returning people to activities, to works. Interestingly, though, outside is return to full activities outside the workspace. So difficult to manage patients like that. Difficult to manage expectations of an employer. Okay, very difficult to then, even though in your heart, in your hunch is, you playing me, you playing the system, you playing the game. I can't turn around and tell him exactly that. Okay, because then I'm going to get a complaint against me this time. Okay, and so managing those black flags, patients. And again, I'm labeling a patient here, but it's easier from a teaching standpoint, is difficult. Okay, the likelihood is there's also some yellow flags. So you may notice that I tend to maybe less compassionate than some of my peers. Okay, I tend to have less patience, and maybe something I need to reflect on sometime. But there's so much you can do. Okay, and when there is a clear barrier put in place, until that barrier is addressed, And here, when the claim is settled, okay, then will the patient move on? Okay, and I've seen it sadly countless times. Okay, I have seen patients using scans of historical conditions to get out of working, but as a result, they've put themselves in difficult positions, so creating financial issues for themselves. When those financial issues have snowballed out of control, where they've become now very anxious because they can't pay the bills, they can't pay the mortgage, but then they've antagonized the employer so much that the employer is now not willing to have them back until everything is settled. And then what starting as a small thing can snowball out of control very quickly. Okay, for me, those start to become red flags in essence as well, whereby anxiety levels, frustration levels. I've had patients who've become suicidal at this stage. Okay, just because of their behaviour to start with, advised by the unions to behave in a certain way, but creating more frictions within the workplace, for example, and ultimately the consequences were for them, not so much for the employer. Okay, so red flags. So, are you happy with this? We're going to explore those a little bit later. Okay, so the idea today is to have an understanding, knowledge of red flags and the relevance. Okay, explain clinical reasoning with regard to red flag and some of the common example of red flags. Now, again, those sessions in the graduate development program are for you to be aware, okay, to start to grasp some of this concept from a clinical standpoint and less theoretical standpoint that you may have had at university. We will explore this in the next at level 5 teaching, you know, in the accelerated development program that will start in January. We will have more red flag sessions. You will have more red flags. You'll have more session on communication. You'll have more session on subjective evaluation, objective evaluation, clinical reasoning, governance, and stuff like this. So do not panic, please. Okay? And please step up and step in and ask questions. Okay? So red flags is more from a observational standpoint than true, you know, studies. Okay, it's addressing patient concern perception and how we influence those. Okay, and questioning. We talked about subjective reasoning last time. Is that what are the aims of your assessment? Okay, and then I always have in mind when I see a patient for the first time, within a few seconds where I want to go. Okay, and what am I aiming to do? Okay. What do you think the aim of the assessment is when you see a new patient?
To sort of rule out anything that you think's more sinister that might need sort of onward referral. So say if somebody came in with back pain, you're going to sort of go through screening for sort of cardiac weight, and obviously if all your screening for that's negative, then obviously you've got that sort of comfort blanket that you don't have to sort of make an urgent sort of decision on the spot, that you need to sort of be referring them sort of for urgent treatment.
So that's the focus on the red flag. Okay, so one of the aim of the assessment is to exclude as best as you can sinister. Correct? Mm-hmm. What else? What are the aims of the assessment? Maybe take a bit of a broader approach.
I think another thing you want to focus on during the assessment is what their goals are and what their expectations are, so you can develop a management plan that's appropriate for them in their life and their lifestyle, for example.
So what's meaningful for them? Yes, absolutely.
Well, they come to us because they were referred even by a GP or self-referred, and our goal is to understand how we can best help them with their problem. So
are you telling me that to aim to assess what is important for them?
Yeah.
What their concerns are?
what their concerns are and how can we help and if we can help, because sometimes it's better to refer to another professional that might help them better.
Have you listened in to clinics and interaction of a patient? The referral is for back pain. Okay, when as the conversation starts and goes on, you start to see that the patient's back is not his concern, but the concern is something else. That they've deviated completely. Yeah, I've been referred for my back, but you know what? I've had back pain for ages. You know, I'm more concerned about the fact that, you know, can't play with my kids, you know, and I don't know how to deal with it. Have you heard this in conversation with the physios that you've been shadowing?
Yeah, and I think that's why it's important to establish, not trying to drill down and find a specific tissue that there's an issue with, but find out functionally and lifestyle what they're struggling with and what they're unable to do, which then feeds into your goals and figuring out what they want from it.
Absolutely. So it's trying to have I tend to approach a patient and I've got a referral. Okay, if it's an acute injury, that's easy. Okay, but even then you will need to evaluate where the patient is at in their life journey, in their health journey, their beliefs, you know, their understanding, their rationale, what they've been told, you know, what they've picked up from social media, and what nonsense they have in their mind, in their brain. The amount of time I hear about, oh, my posture is wrong, you know, and it's linked to my back. So back pain here is not the issue for me. It's the belief that the patient has as to why his back is sore. Okay, so the aim of the assessment for me is to get an understanding. Okay, yes, there are must do. Okay, there are things that you need to exclude, your red flags, your sinister pathologies. But the idea of it, the aim of the assessment is to get a really good understanding of the person you have in front of you. If you guys came to me with some knee pain and I just, it's your ligaments, your meniscus, I need 2 minutes to evaluate that. Okay, but I think I need to go a lot further than that. If I've got Joanna on the video here, I was only trying to find out where she comes from, what she wants to do, how she does things, how often she does things, when she does things, how it impacts on her, job as a physio, why is she not doing the things that she should be doing, and so on and so on and so on. I will certainly exclude the fact that she may have septic arthritis because she's young and she's coming with a knee problem with no trauma, but she's traveled to Zambia and she was bitten by mosquitoes, and as a result she's developed a massive septic arthritic knee. Okay, but that's if I exclude that, you know, the rest I need to understand who Joanna is. Okay, so that's, in my view, that's very much what the aim of the assessment is. Okay, so you have must-dos, exclusion, but also understanding of who your patient is, so that we talk about, you will have an individualized approach, shared decision-making, meaningful goals. Those hopefully will no longer be mere concepts, but we'll start to see this apply in daily practice. Okay, Kelsey, I saw you coming on the video. Did you want to add anything?
No, I think I just
press the wrong button.
I agree what you're saying about it. It's just really about anytime I get a patient, no matter what their pain is, no matter what should be done for knee pain, or what should be done for hip pain, if it doesn't match that person's lifestyle, if they're working full time and they have kids and they're not there, I don't have time to exercise. It's really about listening to all the stuff that they are saying before you can actually send them home with anything, because you could send them home with the typical exercises for whichever body part they're hurting, but they're not going to do it if it doesn't match what they've told you about their life.
Absolutely. So here, as we're going to move more into red flag, but as a general comment, and I'm studying this at the moment, so for my master's, so I'm ticking a box here for my master as well, but I think it really applies. Start to think what it really means to be a physiotherapist in this era, okay, compared to what it was 50, 60 years ago. Okay, what do you want to be? Okay, some will want to be the sports physio who want to work on a football pitch with acute injuries and use all sorts of weird and wonderful devices on a £50 million football player. Okay, others may want more towards into with older people in more chronic conditions. So the skills, the competencies, but who you are as a physio are very different. Okay, very, very different. However, I think the approach will still remain the same into your understanding of the patient. The fears of a top football, a top professional sports person are certainly, in essence, the same as an older person to be able to do what they're supposed to be doing. Okay, but how you approach that, what skills you use, what abilities, flexibility, creativity that you need to have are certainly different. Okay, and I think you need to start to really look at who you are, what your focus is, what you enjoy, what is meaningful to you as a physio as well, when it comes to then, once you've done your assessment, as to how you're going to approach patients and your management. Just food for thought here for you guys. So, little quiz, red flags. So we've talked about those flags. Okay, I think this is what I think we've discussed already. So you're red, orange. I think it was somebody didn't know what the sort of mental health illnesses come under. More the orange one, yellow, blue, and black. Okay, so there's also something called pink flag, in case you wondered, and you will certainly come across, which are more the willingness of more positive flags. So the patient is willing to engage, willing to return to work, willing to do the exercise, motivated, high self-efficacy values, that sort of things. Okay, because you will have those patients that do not have that drive, and you'll have the patients that do have that drive. Okay, so you may encounter the term pink flags. Okay, so what are red flags? The features from the patient clinical history and physical examination which are thought to be associated with a higher risk of serious pathology. So I'm going to introduce the concept of index of suspicion here. Okay, and when you talk to your patient, it's this index of suspicion that goes up or down. Okay, that you need to start to develop. Okay, so potential pathologies, tumors, infection, fracture, CS, structural deformities, HIV, all sorts of different pathologies, neurological one, respiratory one, cardiac ones. Start also to think multi-system. Now, does somebody understand what I mean by this? Thinking multi-system.
So you're not just looking at MSK, you're looking at like arterial function, nerve conduction, looking at the body as a whole rather than just focusing on kind of what our job role entails, I suppose.
Yes, absolutely. Too often we start, we rely on the musculoskeletal. So now you bone, tendon, ligament, joints. Okay, but you need to think big time around lymphatic system, respiratory system, vascular system, neurological system, kidney function, reproduction organ system, bowel system. They all can and will mimic certain musculoskeletal condition. Okay, as an example, some people come with shoulder pain. He's in his mid-60s, is a smoker and drinker, and has shoulder pain. It could be just shoulder pain, okay? But you start to have maybe some indicators that could be something else. You could be looking at potential lung apex tumors, cardiac dysfunction, angina, okay, things like these that may mimic as a shoulder problem. Okay, so when I talk about there's a reason why we ask to the patient, are you well in yourself? Any medical condition, medical history. So we talked about last week about subjective, there was hopefully you've picked on the fact that we focus quite a lot on the medical history or the existing medical condition of a patient. Okay, this is why, because there can be indicators of red flags. Okay, which one do you know that could be indicators of red flags? So if we move into subjective markers of red flags, go. If you don't want to come onto the mic, you can use the chat.
Sudden weight loss.
Pain. Okay, for whoever put something, I would like them to tell me what they're thinking behind it. So Caroline, if you think bilateral leg pain, what have you got in mind?
So thinking sort of nerve related, like cauda equina, one of the cauda equina symptoms.
Okay, what else could it be bilateral leg pain?
You could be looking at a myelopathy.
A myelopathy? Yes.
Dangerous, the sort of more risky stuff.
Yes, it would not be so much pain. It would maybe present more with a motor dysfunction. Okay, there could be some pain. What else if you have bilateral leg pain? I want you to think on that one.
It depends kind of how you're describing it. If it's all the way down the leg, then obviously you're thinking more something serious, or it does raise your index of suspicion, but it could be referral from the back or something from the hip. So you kind of really need to gauge if it's full.
Okay, but let's say we have bilateral leg pain all the way down to the ankle.
Okay. Sciatica. Ridiculous thing.
Sorry, I had a problem with the connection. I lost everyone for a few seconds. I don't know who was talking. Lewis, was it you talking? Yeah. Hello?
Hi, yeah.
So if we talk about bilateral leg pain down to the ankle, we talk about cauda equina, potentially, yes. What else could you think? When I talk about multi-system, what else could it be?
Sorry, you broke up quite a lot before that. I couldn't hear what you said before then.
How about vascularity issues?
Okay, so potentially like AAA, things around that.
Absolutely. Okay. It could be commonly like artery stenosis. Okay. You could have a bilateral distal stenosis, popliteal artery, femoral artery. Unfortunately, it happens. Okay. You could have, yes.
Neurogenic claudication, so like from a stenotic picture within the spine for like older patients.
Absolutely. You could have, and that the stenosis is a genic term because stenosis could be multi-causal. It could be a fracture, it could be a disc, it could be a lesion, it could be bleed, it could be you name it. Okay, so just one subjective marker of bilateral leg pain can need to start to make you think as to the cause of this as well. Sexual dysfunction, Lewis. Yes, absolutely. What do you have in mind here?
So they're really quite personal questions, but quite important for cauda equina screening. So pain during sexual intercourse, the inability to like maintain an erection, things like that.
Yeah. So what are they indicative of this?
What do you mean? Sorry, I don't understand.
Well, why would you have sexual dysfunction?
Oh, right, because of the nerve supply that obviously cauda equina supply. Those nerves also supply bowel, bladder, and sexual organs. So you need to cover those questions.
Absolutely, but taken into isolation, sexual dysfunction. What else could it be?
Problems within the bowel or bladder themselves. So not just obviously cauda equina, but thinking outside the box from like don't know the right word, but looking at it from like a women's health or men's health perspective. So appropriate signposting if that's the case and it's not related to cauda equina.
Absolutely. There you go. It could be a prostate issue for men, for example. Okay. Indeed. So you could have other issues associated with it, drug use, infection. Okay, so you can start to see that we will certainly need to explore more and more around the patient's lifestyle, for example. Rosie, waxing and waning of pain irrelevant to activity. Come in on this.
Sorry, I also missed the word joint in there. In a joint or in a bony bit. It was one of the indicators for the osteosarcoma thing for cancer, bone cancer.
Absolutely. Often at night. Okay. So sudden unexplained weight loss. Kim, do you want to come on the mic, please? Explain that to us.
If it's very sudden, then you could be looking at potential cancers. Obviously, that ups your metabolic rate. You're burning a lot of calories, so you could have unexplained weight loss. Obviously, that would be more alarming, hand in hand with other things such as history of cancer.
Yes, absolutely. Is this weight loss often sudden?
It can be very rapid. Yes, but I think unexplained is probably the main thing. If somebody hasn't changed their eating habits at all, then that's obviously going to be concerning. Absolutely.
How much is unexplained weight loss significant?
I think with significance, again, it comes down to putting it hand in hand with other things, and I think that's probably the case with all red flags. You can't really take something.
But when would you start to have? When will your index of suspicion start to rise with unexplained weight loss? Do I need to lose 5 kilos? Do I need to lose 10 kilos? Do I need to lose 15 kilos? 3 kilos?
Depends on starting weight, of course. I mean, if somebody's very slim already and starts losing more, that would be more concerning than say somebody who's bigger, because obviously you lose weight faster if you're already overweight. I think it very much depends on the person and their starting weight, really.
There is still a sort of indicator. We're looking at about 10% of existing weight over a 3 to 6 months period.
Yeah, so 10% of their starting. So
yeah, exactly. You may encounter, for example, patients who suffer from anorexia, but then the weight loss will fluctuate downwards quite a lot. Okay, and often you may not get an answer, a proper answer, unless you start to speak to the parents potentially. You can have metabolic issues associated with weight loss, okay? Diverticulitis, Crohn's disease, other sort of inflammatory issues that would explain the weight loss. Thyroid problems can lead to opposite, okay? So weight gain, but also I think if you're hyperactive thyroid, weight loss. So there are other reasons for this. Infections, metabolic disorders would explain those as well. There may not be a sign of cancer in itself. Okay, Joanna, sleep dysfunction. Can you explain a little bit on this?
Yes, so it can be due to several things, really. So it could be more of a yellow flag because it can be anxiety or depression related, like mental health issue related, or it can be related to some dysfunction in your respiratory or cardiac system, like sleep apnea, for example, or it can be just due to pain. You need to understand why that person is not sleeping well too.
Exactly. So don't just stay. You raise a very good point here, Joanna. It's not just how is you sleep? Oh, I can't sleep much, and then you move on. You say, so why don't you sleep well? Oh, I worry too much. Okay, so you know that's a bit more scientific. Or my back pain is excruciating and never go to sleep. Okay, are you able to go to sleep or do you wake up? I'm able to go to sleep, but I wake up when I turn, as opposed to I can't go to sleep. Okay, subtle differences, but conclusion may be quite different. I can never go to sleep because of the pain, as opposed to I can go to sleep, but then I wake up when I turn. So movement in the second one. In the first one, the person cannot go to sleep. Okay, so here pain is such that the severity is so high that the person cannot even go to sleep. So this is more high index of suspicion, as opposed to the person who has back pain, goes to sleep, but then turn from left to right and then is woken up because the pain is excruciating. Okay, so explore those questions. Rosie, Trizer indicator. Now I want to know what that is.
Sorry, that was related to the weight loss thing.
Okay.
In school, we had the trouser indicator. So you asked how your trousers are fitting now, how they fitted 2 weeks ago, 4 weeks ago, 2 months ago, and if they're affected by if you get bloating or not. So that can indicate whether it's digestive issues or if it's like a sudden weight loss for cancer. There's other things, but I've totally forgotten them. But it was just that.
Good enough for me. And Lewis, yes, you're right. Index will be raised with past history of cancer. Absolutely. What else, guys? What else subjectively that you need to explore that will make you feel like, oof? I think Joseph is writing. Maybe come on the mic.
Yeah, but I'll come on the mic. Just thinking of like sort of the mechanism of injury. So if you get a patient who's had a traumatic injury and you're the first person who's seeing them, and maybe it's coupled with like another risk factor of like a age of over 60 or something like that.
Yeah. So you've given us already, sorry to interrupt you, Joseph, but you've given us two subjective, age and mechanism of injury. Absolutely. Yeah. So link the two. Imagine you got a 75-year-old woman who comes in with back pain after missing the last step on the stairs.
Well, then you just, from my point of view, send them straight to A&E for an X-ray because it just
yes. Okay. Back off a little bit. But what would you start to think?
Well, your index.
So she hasn't fallen down. She's just walking down the stairs. She missed the last step, landed heavily on her foot, and she's got back pain. What could it be?
Well, from that, I'd just go with a fracture, really.
Yeah, fracture of what?
One of your vertebral bodies in your spine.
Yeah, so you could have this, for example, 75-year-old, potentially osteoporotic. So, but you would then have to explore, do you take any medication? Oh yeah, I take calcium and vitamin D supplements. Okay, and then I had a scan that showed that I had osteopenia. Okay, yeah, compression fracture, Kelsey, absolutely. Possible osteoporotic fracture, absolutely. So age and mechanism of injury, beautiful. What else as subjective indicator? So these are the questions you want to ask to clear those potential red flags. Yes, absolutely. Drug history. What would make you think something is in the drug history, Lewis? Do you know some of the medications that could make you think, okay?
So I can't remember their name, but like alendronic acid for obviously things like osteoporosis, if they're at risk of that.
Steroid, yes. What? Absolutely. Both of you are very right. Steroid. So you have this bodybuilder that comes in, is built like a brick shit house, and then has some, I don't know, ruptured his bicep tendon. Okay, and it's suddenly you look at it. Oh no, I don't take steroids. I say, you sure? So these are difficult questions. This is a difficult conversation to have. Okay, there's the absolutely. Yes, Kelsey. okay, the COPD patient who also use inhalers, okay, who could have so steroid inhalers. So both of you, important to link this. So what do steroids do? They have an impact on the integrity of our tissues, okay? So it could lead to, and also on the vascularity, absolutely. So fractures, ligamentous rupture, tendon rupture, vascularity issues. What else?
You could ask a bit more about the pain in detail. So, like, is it band-like? And
yes,
back to the sleeping. Back to the sleep. Is it getting worse when you're lying down? Is it ease when you're sitting up?
Okay. What would this indicate for you? What are you thinking? What lines? What's your thought process here, Emma?
Like if there was answering saying that it was worse when they was lying down, like a potential malignancy.
Yeah, absolutely. Often we find a band-like around the thoracic area. Okay.
Yeah.
Yes, metastatic spinal cord compression. Absolutely. What else would you have then with an MSCC, Kim? What other subjective symptoms you may have?
So obviously you're looking at history of cancer, or potential history of cancer anyway. MSCC, if you've got spinal cord compression, then yeah, you're looking at more of those symptoms related to that. So some of your more, I suppose, depending on what level, but your more radiculopathy type symptoms, motor function issues, ataxia, things like that.
Beautiful. Absolutely. Absolutely. What else? I could carry on with the what else. Caroline, instead of typing, come on the mic, switch your video on. I'm the only one on screen at the moment. I feel under the radar. A lot of people are typing. It may be easier if you're happy to do so to come on the mic. Age, yes, below 20. Yes. Why, Joseph?
Well, if someone's coming, let's just say back pain, and they're in like the range of like a 20 to 60 or something, then that's more indicative of something like more mechanical going on. But if someone's under 20 and obviously they're still developing like as a person and everything, then that's a red flag, because you start to think that these people aren't doing anything to mechanically injure the back. So you just got to think sort of outside the box at that point.
Absolutely, yeah. So your pediatric or young adult population, and the same with age. Anyone above 50. So you start to think, other things, because we know, or we have an understanding. Some pathologies develop after 50, for example. Good. So age of onset, trauma, constant thoracic pain, past medical history, systemic steroid, drug abuse, HIV, systemically unwell, weight loss, persistent severe restriction, lumbar flexion, widespread neurology, structural deformity, past medical history of cancer. Okay, keep in mind that the most common metastatic one, breast, lung, and prostate. So keep that in mind. Okay, sadly for me, I've had all three presenting as musculoskeletal issues in my career. I've had 3 breast cancers, I've had 1 lung, I've had 2 prostate ones who had metastasized. Okay, changes as well. So changes is important. Okay, it's something that you need to start to think about. So try not to think of the patient as a static person when they come to see you. Where are you at today when I'm talking to you? But ask about changes over a period of time. If the person is talking about bladder issues, you got a man over 60 coming into you and start to say, yeah, you're urinating more during the night, to get up 2 or 3 times a night. But this has been, long standing for the past 3 years, as opposed to, yeah, this is quite new. It's been ongoing for the past 3 months, 3-4 months. Okay. the index of suspicion changes again. So ask question around change, okay, and how long has this change been ongoing? Sores that do not heal, okay, unusual bleeding or discharges, okay, so thickening or lump in breast or elsewhere, indigestion, obviously change in wart or moles, nagging cough or hoarseness, okay. Think, as I said, this is what I mean by think multi-system, okay. When you ask a patient, are you well in yourself? And the patient say, well, I guess I am, you know, I'm not happy with this sort of answers. Okay, I then go, well, tell me more about it. Sometimes you can just go, do you have any heart-related problems? Do you have any chest tightness? Be more specific, yes or no, as opposed to tell me more. Okay, important to really address those, so then you can relate them to a pathology. Just to give you an idea, and I'll give you a case study in a second, but vast majority of patients come to see us due to pain. So what do we need to know and why? Okay, and this is where, again, your questioning and your ability, your capability to elicit answers, and what you have in mind is, why do I ask that question? Why do I want to know that? Okay. Now, please don't go after today's session and start to question all your patients because you think they all have red flags, okay? But be very clear as to what you want to get to, okay? So frequency, location, timing, okay, are all very important, okay? Location, thoracic pain, most common region for metastasis, okay? It's most common, not all the time. The prostate patient that I had who had metastatic cancer was in the cervical spine at C7, for example. Okay, least likely spinal area of disherniation and nerve compression. Indeed, okay, thoracic is not so much there. So if you have something happening at the thoracic spine, somebody mentioned band-like, I think it was you, Kim, I think, mentioned band-like pain, you tend to have it around the thoracic area, but it could also be anything related within this thoracic area: lung, heart, thoracic aortic aneurysm, so vascularity, organic. It could be liver, it could be, if it's a bit lower down around the kidney area, it could be pancreas. Okay, if they've been in a fight, it could be a low bleed, spleen, you know, things like this. So this is what you need to ask questions. I had a patient who came in to see me who had been in a fight, but who had chest pain and abdominal pain for about 3 weeks since the fight. Okay, so I wasn't too sure what was happening. He reported there was a lot of bruising at the time, but hadn't been to A&E. Okay, he went to A&E, there was nothing really, but I was concerned about potential organ damage. Okay, and because that was not abating, that was not changing, when you would think, but he was doing something very physical from a work standpoint. So really difficult to gauge this. Okay, so just to give you an idea, a case that came to my knowledge, a patient, lady, mid-40s, came in with shoulder pain on the left side. She didn't have any signs and symptoms other than shoulder pain. The only aggravating factor was every time she drank alcohol, her shoulder pain got worse. And that was it. Any ideas? Pancoast, liver, no and no. Gallbladder, no. So it's interesting because you're already thinking organs here. Do you think, based on this information, do you think it's mechanical? And on assessment, objective assessment, she had full range of movement, no pain at all on movement, no pain on resisted movement, active and passive were the same, no cervical dysfunction, no thoracic dysfunction, no issues whatsoever. It was the left shoulder, Joseph. It wasn't inflammation, Joanna. I'll leave you to mull on this. Think about it. Okay. 45, Lewis. So members of development group were then, so we're talking about the weighting. I'll leave you to think about it, okay? And you can use the chat to give me your view on this, okay? So so reaching agreement. So interestingly, level of agreement around 75 to 99% weight loss and previous history, okay? With a majority view, 51 to 74, so that's quite low. Night pain, age above 50 years, violent trauma, fever, saddle anesthesia, difficulty with micturition, intravenous drug misuse, progressive neurology, and systemic steroids. Okay, so when we have those weightings, 100% is agreement, unanimity. So there's a majority view, but it's interesting to see, things like saddle anesthesia. Okay, for a majority view, yes, it's indicative, but there still leave quite a few people, not convinced by this. And I think you just have to look at the CAS guidelines that Connect has developed and the fact that they've been updated and what action is to be taken. Okay, I think there's still some element of controversy. Terry, why don't you come on the mic instead of typing? Spleen? Am I? I'm afraid not. I'm afraid not. Think about booze. It's the booze that made it worse. So, weighting of red flag in practice. Was she passing out on that shoulder? No, Kim, she wasn't passing out at all. I'm glad it's making you work. Were you thinking heart?
No, I was thinking more that she was having a drink and coming back from the pub and then sort of passing out and sleeping in the same position all the time.
So you're thinking mechanical?
Yeah.
That she's an alky. That she's an alky. She can't take her alcohol, and then she lies on the left shoulder, and that's it.
Yeah,
no.
It's been done.
I'm sure it has been done. Cancer of what, Jordan? That's too broad, too wide. Commit. So. Lung, no, Kelsey. It's not lung. So kidneys, I'm afraid not, Lewis. Reflux, no, Kim, no reflux. No, not breast, Cheryl. But it's good, it's making you think. But why is it alcohol that is triggering shoulder pain? No, Jordan, not Hodgkin lymphoma. It's not the liver, Joseph. You're missing. This is when maybe you need to know your physiology and heart issues due to increased. No, Rosie, I'm afraid not. So, in the meantime, throat. No, I'm afraid it's not throat. Throat rarely could refer to the left shoulder, but it's rare. Okay. Tell us. Physiological, psychological in nature. Oh, Cheryl, no. That's a good shot, but no. No. Do you want the answer? Rosie said yes. I want more than one yes to give you the answer.
Could it have like neuropathy because of the alcohol? Okay,
so in the short answer, no. But when you have referred pain, usually is because the innovation allows you to have that. So I've got 4 yeses now. So I'm going to ask you to give me I'm going to question you. Which organ processes alcohol? And what's in alcohol that needs to be processed by that organ?
As long as it's not a trick question, liver.
So liver is one, but liver doesn't work on its own.
No.
What does it work with? What is in alcohol? No, Jordan, not lymphatic. What is in alcohol? What's the main component of alcohol, apart from alcohol?
Sugar.
Ethanol.
Sugar. Indeed. And water. A lot of sugar. What organ allows you to process sugar?
Pancreas.
Yes, by releasing what?
Insulin.
Yes. So the pancreas here was the culprit. It was not working anymore due to a tumor. So every time it tried to do its job, it created a physiological change, inability to release insulin, and it was referring pain into your left shoulder. Outcome of this lady, she was dead within 2 weeks of being seen in physio. She had a very advanced pancreatic cancer, and within 2 weeks she passed away, sadly. Yeah, wow, Lewis. So, and she had no other symptoms. She had no other mechanical or any history of cancer. There was nothing. She was not taking any medications. Okay, so this is just to highlight that something can masquerade as a musculoskeletal issue. Okay, the cause is obviously here. People knew there was something that wasn't mechanical. Okay, but it was too fast and for it to be diagnosed, and I'm not too sure anything could have been done anyway for this poor lady. Okay, so this is to highlight as well that you don't need to have the signs, subjective signs, to identify red flags. Sadly, a lot of red flags that we take for granted, that we want to see, sometimes are often not there, and yet you still have a serious pathology. Okay, so hopefully this put you out of your misery. Weighting of red flags in practice: age over 50, history of cancer, unexplained weight loss, plus failure to improve after 1 month. So they all added. Okay, age under 10 and over 51, medical history, current of cancer, tuberculosis, HIV, osteoporosis, weight loss over more than 10% of body within 3 to 6 months. Okay, severe pain precluding sleep. Okay, loss of sphincter tone and altered S4 sensation. Now, by the way, okay, know your scope of practice. Do not go testing sphincter function. Okay, that make me laugh, that make you smile behind your screen. But sadly, I have heard of physios having tried to do it, and obviously have been out of the scope of practice, and have had to be sadly reprimanded. Okay, so don't go and do the reflex with a cotton bud, please. One red flag: age 11 to 19, weight loss, constant progressive pains, band-like pain, abdominal pain. So this is also this population, young population, that should not have pain in general unless they have maybe already known condition. I don't know if you see, I don't think you see pediatric patients in your practice, do you? Anyone see any peds? No, okay. But if you do some practice work, some private practice work, you may be exposed to those, okay? So when I see a young person coming in a private practice, okay, with no history of trauma or anything like that, I immediately have some alarm bells, and then I tend to be more very aware of what I need to explore, okay? Some of you may be doing, sports physio on weekends, helping with a football club or their rugby club, netball club, basketball club, that sort of things. Be very aware, okay, and do your due diligence, okay. If you're going to start to work in that capacity, you need to be writing notes, you need to be recording things, okay. So further red flags, further information: so loss of mobility, leg misbehaving, odd feeling in legs, So smoking, systemically unwell, trauma, pins and so we've explored some of those, but there are even further ones. So I recently had a patient with early onset of MS, okay, and she presented with slight loss of mobility, foot catching on the stairs, sort of burning sensation in the legs bilaterally, sometime loss of balance, but not really evident. Okay, and there was nothing in the history that suggested, you know, a disc pathologies or anything like that. It was very diffuse and broad. Okay, she ended up being diagnosed with having had a one-off event of MS. Okay, so keep these in mind as well. Now, something that is important, okay, is how can you go wrong subjectively? Now, do not panic again, okay, but those things tend to come up on a regular basis. So undefined terminology or too complex, okay, using terms the patient doesn't understand. Be simple, stupid, okay. Lack of knowledge, okay. So in case that you're not sure, ask your senior, ask the CATS clinician if they're around, ask an APP if they're around, ask your team leader, okay, because at the end of the day it will be your neck on the line if you haven't identified something, okay, that was glaringly obvious. Choosing not to ask certain questions. Was it you, Lewis, who was talking about this?
Don't think so.
And the difficulty of asking question around
cauda equina questions.
Yes, absolutely. Have you had to ask those questions already, Lewis?
Yeah.
So can you give us how you approach those? Can you tell us and share your experience with this?
I always try and kind of frame it beforehand to say, obviously these are quite personal questions, but really important because the nerves that supply the back also supply all these other areas as well, and then just try and gauge from there. But I don't jump straight in because obviously it seems a bit weird, especially from a male talking to a female perspective and over the phone.
Yes,
just adds to that. So it's
good. So is the preparation preparing the patient to be exposed to those questions?
Yeah.
Do you know the difference if you have to ask a man versus a woman around sexual dysfunction? What sort of question do you need to ask if you're a man versus a woman?
So for man, it'll be the ability to maintain an erection or even get one in the first place. And for women, it's pain during like penetrative sex.
Yes.
Women can also be inability to orgasm as well, isn't it?
Correct, as well as loss of reduced sensation during intercourse. Okay, so that leads to the lack of orgasm. But sometimes also before going there, ask, do you have normal sensation when you have intercourse or rapport with your partner? Okay, if she says yes, but I suspect this cauda equina syndrome, I will then move towards the question of climax. Okay, but you got to be very careful, very sensitive. Okay, ask those questions if you strongly suspect, okay, that there is CES. Okay, or I mean, explore them further if you strongly suspect that there is the beginning of. The issue is with CS, and this comes from a conversation I had with a neuroconsultant, a neurosurgeon. When you have cauda equina syndrome symptoms, have you heard of white flags with regard to CS? Yes, Rosie, that can be a red herring for birth control. Yeah, absolutely. Have you heard of white flag for CS?
So is that when symptoms are kind of at a point where it's irreversible?
Absolutely. Who was that? That was you, Lewis. Yes, absolutely. So when those symptoms are sadly already present, okay, and you raise a white flag because you want it to stop, okay. What are the guidelines when patients present with cauda equina syndrome? What are the guidelines for addressing those? Or what should you do? So if you're not familiar with this, please do review Connect's internal cardiac arrest syndrome guidelines. Okay, the referral, the letter, calling A&E, speaking to registrar. Okay, you should have those. But how long has a patient got, according to NICE guideline, to be operated on to try to avoid further deterioration of symptoms and be left with permanent damage? 48 hours, yeah. 48, Fionn, Caroline, 48, yeah. So these are the guidelines, okay? When I spoke, and this has stayed in my mind, when I spoke to that consultant neurosurgeon at King's College Hospital, his take was 3 hours. Okay, so this is what we talk about. I think what we talk about white flag, and I haven't reviewed the literature on this paper, so I can't really comment on the time frame that is raised in this paper. But 3 hours is usually the time frame that you want to be operated on. Afterward, that consultant suggested to me that you will be left likely, in all likelihood, with some form of neurological deficit. Okay, be it bowel, be it bladder, be it pain, be it weakness in the legs, sensory loss, you name it. Okay, so just be aware of that. I'm not saying that you need to say that to all your patients, please. Okay, but I want you to have a critical mindset when it comes to this. Okay, and therefore you need to act obviously very quickly if you are presenting with this. Okay, the guidelines are 48. Oh, there you go. So I just had to admit somebody. So the guidelines are there, okay, and they're obviously based on many consideration, and certainly many people have contributed to those, okay. But it was, for me, it's always been interesting to see those guidelines in light of that conversation that I had with that neuroconsultant surgeon, okay, who had a much shorter time frame. I guess he's certainly looking at the safety side of things, and the sooner you did, the better. Okay, because when ischemia sets in, I guess the affected neuron will not recover. Happy with all this? A quick thumb up or yes or whatever will help, will be good. Yep. Okay. So exploring a little bit about, lovely, thank you very much, about undefined terminology. You know, have you suffered from any recent physical trauma? Okay. Some people may not understand the word trauma. Keep that in mind. Accident, injury, choosing not to ask certain questions. We're talking about sexual function, but a big one is dependency as well, drug and alcohol use. Okay. So as Lewis said, important to provide patient with context as to why you need to ask those sort of personal question. Has somebody ever had to deal with people who are intravenous drug users or alcohol dependent people?
I haven't dealt with them any of them personally, but during shadowing this week, there was a patient who had a history of heroin abuse and alcohol use. And during the consultation, the team lead who was questioning would ask around, oh, do you take any other medications that are non-prescribed, and trying to delicately give him the opportunity to say. Yeah. And he wouldn't disclose it. He wouldn't tell us about it. And we can't say, well, we can see in your history that you've been admitted to A&E and for these reasons. So we just kind of had to say, okay. We kind of had to take his word for it, even though we've known the history. But it was definitely something that we had to think about in terms of what next steps for management were. Cause I'm in the pain links in Lincolnshire as well, so there's a lot of referring for medication reviews, and that wasn't really something that we thought would be appropriate due to history of addiction.
Absolutely. So it's a difficult one. You're right, Kelsey. I mean, it's a very difficult one, and here it's good that you had a history. okay, of his hospital admission for suddenly overdose, I guess it would have been a OD'd, or maybe picked up because of infections, and therefore the history suggested that infection was due to misuse of needles and or in an unsafe way. Okay, but sometimes you may feel you need to push. Okay, because it will suddenly highlight, and particularly when you find nothing, okay, but you suspect there's an infection cause, okay, and then there's no history of traveling, and there's no, but then you can try to link it to the social context, the work context. Sadly, those people are unemployed. They will live maybe in accommodation that are maybe not fit for living. So it's also asking all around the person in order to try to get an understanding. And sometimes I have asked, it says, I've been really blunt. I need to ask those questions, to exclude any infections whatsoever, any other medical history. So I said, what are your medications? Do you use any drugs or anything like that? And I do say, by the way, everything you say is confidential, so do not worry about it. And I said, and that's it. And do you do any illegal substance usage? Yes, no. If you do you inject at all? Okay, and if they're a bit cautious, say the reason I ask is because of risk of infections. And in your history, what you're telling me, I'm struggling to find anything at the moment. Okay, sometimes it can be a bit difficult, yeah. But if I feel I need to go there, I won't hesitate to go there. Okay, at least I think I'm doing my due diligence by asking the question. Rosie, thank you very much, Kelsey, for stepping in. Rosie mentioned Xanax addiction. Think about also maybe more in Northern America, opiates usage, okay, and the use of the likes of OxyContin in particular, and very, very strong opiates. Okay, good. So we talk about lack of knowledge, so newer red flag. This has been addressed already. We've discussed this. What I suggest we do is 11:15. 10 minutes break, guys, before we look at the objective aspect of red flags. Okay, have a breather and resume at 10:56. Okay. Welcome back, everyone. Are we all back? Hello, Rosie. Kim, everyone, cool, nice. Hello, Theon, Joseph, Josh. I dare not pronounce it. Ashling. Have I damaged your name again? Right, guys. Any question on this morning's session so far? Thank you, Ashling. Thank you. Any burning question? Anything that has been raised that you're struggling with? Any reflection already on what we've discussed? Kelsey, yes.
Yeah, I think that it's just sort of highlighting. I think I keep thinking back to the patient that I was talking about earlier, that he was saying that he had sudden weight loss, and like right away the flag kind of goes up in your head, and it's really about saying why, what's going on, what's happened, what's changed. And it turned out that, you know, he had a period of homelessness, so he wasn't eating, and then so he lost, I think, 3 or 4 stone over the last 3 months due to homelessness and not eating. I mean, if you don't eat, you're going to lose the weight. But then he also, after a few more questions, turns out that he also started gaining weight back since he's been in housing and since he has been having constant meals. So that red flag kind of goes down, and you're still thinking about it the rest of the time, but it's not as big of a red flag as just, have you lost weight? Yes. Okay, go to A&E. It's really...
Yeah, no, absolutely. You know, sadly, when we present red flags, you know, this is why I'm trying to have a conversation this morning about this and making you explore those and asking what you think when you have a red flag. But they need to be put in the context of the person's history. Okay, so take your homeless person who's lost 4 stones. Yes, because suddenly wasn't eating well. But you could argue, you know, if he didn't have the weight gain afterwards, or even after the weight gain, he could also have had maybe an underlying infection, okay, which led him to losing weight on top of being malnourished, okay, and then that could have led to, it could have resolved on its own, okay, because of the immune systems. You know, sometimes you get away with it. So it's still, you can still have this index of suspicion. It's just move up and down with your conversation, and as you put it into context, it will raise or it will go down. And this is very important, which is why when you have a patient, you know, we talk, oh, make sure you get your subjective right and get your objective right. Have a conversation, okay? Try to debunk the myth of the assessment. It's a conversation you're having with a patient. You have a referral for a knee problem. Yes, okay. Explore, but explore like, tell me what happened. When did it start? How long ago? What's happened? How's it changed? How's it evolved? Very broad question. Okay, have a chat if you need to. You know, try to see that it's your dad or your mum or a friend or a relative in front of you, so that it makes the reasoning and the searching more friendly, for a better word. Okay, to make it more accessible to you. Okay. Yes, you need to put a thinking hat on, and yes, you need to relate it to your knowledge, okay? But I think, and I believe that when you have that conversation, you will pick up on the things that are just not quite right, as opposed to the things that are, yeah, fine, okay? And then, yes, you have specific question you need to ask, which is why we're doing sessions like this of me giving you knowledge, or at least directing you to some knowledge that you need to then explore further in your practice and in your reading, okay? But you're right, Kelsey, it's within the context of the patient, absolutely, okay? Thank you for raising that, thank you very much. Anyone has any other comments, such as Kelsey's comment, or any questions or any issues, or anything that is not clear from what we've explored this morning? All happy with that? Perfect. No return, no feedback, no yes or no, nothing in the chat. Right, so objectively, can you give me a few objective findings? Thank you, Kim. Thank you, Terry. Objective elements that will confirm red flags. Now, you've explored all subjectively. There is some element of suspicion. We're not going to go into specifics. Okay, what would you want to see? How would you explore that? Observation, testing, objective markers of red flags. I won't say anything until someone speaks now. Neuroassessment, dermatomyotome. Good. Reflexes. Gait, so functional. Gait, yes. Balance. Redness or swelling. Temperature, redness. Okay. Wasting. Noticeable mass deformity, yes. Okay. Bruising, okay. Keep them coming. Coordination. Carry on. I'm going to pick on everyone afterwards. Facial features, yes. Okay. Bit more. Speech, yes. Difficulty with speech. Foot drop, yes. Josh, yes. Caroline. How about the overall appearance of a patient? Such as general health, yes. Movement planning, BMI, yes. Exhaustion, yes. Fionn, frail, yes. Gaunt, yes. Absolutely. Think about colour. Yeah, yellow or grey complexion, pale complexion, yes. Sweaty, if you're perfect. Bookie, do you want to come in on pale complexion? Sorry to pick on you, Bookie. I haven't heard you this morning.
With pale complexion, it's just in terms of how the person looks. So normally pale complexion, they just look like there's no blood flowing around their body, and you can just tell. And they could also look very sweaty or just tired and fatigued. So that's
what will be this indicative of? Somebody step in as well. It's not just a Bookie, this question. Cyanotic, yes. Infection, absolutely, Jordan. Yeah. So the palish, the sweaty, feverish. Heart, potentially, yes, absolutely. Heart dysfunction, a lot of people tend to be fairly sweaty, pale, unwell. Long term, they can be quite cachectic as well, wasted. Cyanotic, yes. Short of breath or struggling to breathe, yes. Kelsey, come in here. Tell us more.
Sometimes if they're struggling to breathe, it could, if they're using a lot of their accessory muscles, for example, to start breathing, it could be some sort of lung problem that's going on. It could be undiagnosed COPD that's not being treated. It could be.
What else could it be? I had one recently. Somebody comes in obese, Short of breath, chest pain.
It could be like a sort of heart attack.
Heart attack, yes.
Heart
what else
condition.
could be?
MI.
Not just you, Kelsey. Angina, yes, absolutely. Stay on the video, please. Don't disappear. Peas, pulmonary embolism, the guy with throwing clots. Okay, but presented with chest pain and thoracic pain. So red flag here for me. Why is it having this? He's morbidly obese. Okay, but he's not very active, and suddenly he's developed a sudden onset of chest pain. So send him to hospital. They obviously ECG and lung X-rays, and they saw some shadows, and he was throwing peas. Okay, for example. Okay, quite a few people talk about neurological evaluation. I think it was it Joanna talked about balance. Joanna, do you want to come in on this?
Yeah, so what I thought was, for example, if you have a tumor or something compressing like the structures of your brain.
Such as, which structures do you think of? Oh, sorry, I'm putting on the spot there.
Yeah.
Help Joanna if you know. This is why knowing your anatomy is also important, okay?
Could be
it's
some
good.
vestibular problems as well.
Pardon?
I was thinking vestibular problems.
Vestibular, cerebellum. I think you're thinking about cerebellar aspect here, Joanna.
Yeah.
Absolutely. What else with balance that could be, if balance is the issue, so if we move a cerebellar lesion is one, what else could it be?
In older patients, it could be something like a normal pressure hydrocephalus.
Yes. What else could it be?
It could be also like circulatory or respiratory related, like not getting enough blood supply.
Yeah. So hypoxia, so problem with the vascularity associated with it, stroke, TIAs. Absolutely. So when you evaluate this balance, it could also be what could you have?
An infection, like a urinary tract infection, for example, in the elderly, or
so they could have sepsis. So you link it to the elderly patient. Absolutely. I can see. Yep. PD. Thank you, Kim. There's a lot of constipation of flight. Yeah, we'll come back to this, Rosie. Absolutely. So Parkinson, motor neuron disease. Okay. Cerebral ataxia, things like this. So think about long-term alcohol abuse as well could lead to those issues as well, and neurological disorders. Okay. So with just one word, balance, that we're starting to have a fair amount of pathologies or potential causes. Thank you very much, Joe. Thank you very much, Kelsey. Caroline, MS, yes, absolutely. Emma, I love the long-term alcohol abuse. People talk about a neuro. What would you expect to see on the neuro? Was it Kim who talked about speech as well? Terry talked about wasting. Terry, do you want to come in to tell us about wasting and what you have in mind with this? Maybe, maybe not.
Oh, here we go. Sorry, my my Teams is playing up a little bit, so
thank you for
connection
coming
issues
on.
and stuff. Yeah, if you hear some random drilling, my neighbours are having some work done, so yeah, a bit of interference going on. So yeah, I was thinking wasting in more of a like a nerve supply to the muscles being interrupted, and then like a use it or lose it kind of thing. So yep. Wasting from that perspective.
Absolutely. Absolutely. But wasting can also be the overall appearance of the person, sort of cachectic, malnourished, or advanced stages of certain diseases, particularly obviously systemic one, cancer, but rheumatology conditions as well. Okay, who will have an overall. You can have metabolic disorders associated with this as well that lead to wasting. You can have and I just had the name and I just forgot it. Neurological condition leading, so not just peripheral nerve, but also maybe central disorders associated with this. Absolutely. Kelsey, redness, swelling. You're on mute, Kelsey.
Sorry. Well, any sort of color around a joint is something that kind of makes me wonder what's going on in there, or just redness if it's not in a joint is probably even more concerning. But it makes me sort of think, what is causing this swelling? Is it just a bit of fluid buildup? Is it something more sinister? Is it a tumor? Is it something sort of gone, like what's gone wrong in that area is what I'm thinking. Why is there a fluid buildup?
So what would redness and swelling, and Cheryl will talk about temperature redness as well, could be indicative of? That's the question to everyone, not just to Kelsey.
It could be some sort of infection starting, or
could be infection. Absolutely. What else could it be?
If you had redness on the calf, back of the leg, that could be a warning sign for DVT.
Yes, absolutely. And Kim, carry on the septic arthritis aspect as well, inflammatory condition as well, Jordan. Yes, absolutely, yeah. Spot on.
So septic arthritis, if you had a joint that was very red, very hot, a lot of fluid, if they were systemically unwell, fever and things, then you'd be concerned about potential septic arthritis.
That's beautiful.
Or infection in that joint.
Yes, very good. So already linking it to other aspects, so as Kelsey said, don't take it into isolation, but bring it within the context of patient. And it's really good that you raise the temperature, the feeling unwell, maybe being sweaty. Often also investigate, have you traveled anywhere recently? Or have you had a small cut or small injuries? So I recently had a fall playing hockey on sand. I scraped my knuckle, and that was 6 weeks ago. It's only now that it's settled, and there was a lot of redness, there was a lot of heat, and there was a little bit of pus coming out, and I thought I'd clean it very nicely. So I disinfected, cleaned it, monitored it. Okay, it didn't go into the joint, but it was starting to get stiff. Okay, and it's still a bit red and a bit swollen. Okay, so maybe I should have gone to the GP to get some antibiotics here. I'll see what happens. Okay, DVT, yes, is an interesting one. DVT, often associated with trauma. Okay, but not necessarily. On your population as well. Okay, inflammatory conditions. Jordan, can you give us a bit of lowdown on inflammatory condition that you know of?
I'm not great on inflammatory conditions.
No, listen, Jordan, that's fine. It's just start a conversation, okay? So tell us which one you know.
So what I was sort of thinking of is obviously rheumatoid arthritis.
Absolutely.
Obviously a bit different from osteoarthritis, but if they've got sort of any of the cardinal signs of inflammation, that's sort of the immediate thing I would be sort of in the back of my mind thinking of. I know there's a tool to screen for that. I think, is it called ScreenDem? I'm not 100% sure what they all mean yet, but I know that's like an to.
Yeah, we'll get there in the rheumatology sessions. But yes, and I'm not a specialist on inflammatory disorders as well. Okay, so RA is one. Anybody knows about other inflammatory conditions?
Sometimes overlooked, but cellulitis.
Yes, IBS. Sorry, Joanna. Yes, go ahead.
No, I was saying cellulitis, infection of the skin. Sometimes overlooked.
Yeah, absolutely. You're absolutely right. And in older people, in particular, this cellulitis is important to pick up. And then you often see this sort of infections in around the ankle. This sort of and then when you press on it, you have this sort of mottled appearance and really thick appearance of the ankle. and that redness that's moving up the leg, and it's very important to pick it up. Thank you very much, Joanna. Good point. Psoriatic arthritis, yes. IBS, yes. Peripheral spondyloarthropathy, yes. Absolutely. Lupus, okay. Crohn's disease, diverticulitis. Okay, people with all those conditions may, yes, colitis. Thank you very much, Jordan, as well. So you have giant cell arteritis as well. So you have all these inflammatory, and then you got things around scleroderma, for example, which is soft tissue involvement. But we move more into the specialist area, the likes of Michael Dare. If you have a chance to shadow clinics in rheumatology, I strongly suggest that you tag along Michael's clinic. They are fascinating. He's an extraordinary clinician with an incredible knowledge in rheumatology, and the way he approaches the cases. Obviously, just if you can, shadow Michael's clinic. Michael Dare is the gentleman to look for. I don't know if you can do that, but if you, as part of your maybe personal development plan, if rheumatology is an element that you want to explore further, you can maybe speak to your supervisor on this as well. Okay, good. It's all very good. I don't think I have got anything to add. So we talked about all those things: pallor, sweating, complexions, tremor, the shaking. You didn't mention. I think maybe some people mention it. Looking tired, disheveled, and halitosis. Yeah. Poor fitting clothes. I don't think I will go and inspect someone's breath, but these are things that you can pick up. It doesn't necessarily mean they have red flags, okay? But you will find you may not have had that luxury or that chance, but it's happened to me once that I've had a patient coming in a clinic at St. Thomas's Hospital with very, very unkempt. To the point where he smelt of urine and feces, had some filthy trousers. It seems that he was coming straight from the street, but was referred for backache, and I can't remember how I handled it, but it was extremely difficult to address. We didn't have any red flags as such, so no judgment or assumptions to be made. Appearance of the skeletal system. I think it was you, Lewis, who mentioned deformities or things that are not I think bone deformities. Was it you, Lewis? I think you raised this up earlier on.
Yeah.
Yeah, absolutely. Have you ever encountered anything like it at all?
No, not at the moment.
Okay. So we took spine deformity, severe limitation of range of movement, rapid onset of scoliosis. So that could be an issue, as opposed to a long-standing one. Obviously, fractures are fairly clear and cut when they're very obvious. So I happen to see some displaced and open fractures. Some happen in clinics. Some happen outside. Often these will not be seen by us unless you work in an A&E department or trauma as a physiotherapist. Okay. Common features of bone tumors, and I think these may be where we need to spend a bit of time. So primary bone tumor is pain, and obviously often non-mechanical, this sort of night pain. And do you know why you have so much pain at night? And why those bony tumors are really, really painful?
Isn't the body's natural inflammation higher at night, sort of the inflammation levels?
Yes, there is this definitely. Keep in mind as well that the periosteum is highly innervated, and often you also have this pain because the periosteum is being stretched and being so sorry, because yes and as a result, bone pain can be absolutely excruciating. So the swelling, the deformities, they tend to occur quite late. Okay. I think what's interesting is the duration of symptoms. 3 months or 6 months or longer is not uncommon. Okay. So you can have pain, palpable mass arising from the bone, X-rays, obviously. So nobody mentioned imaging in the objective, but this is some of the tools that you have at your disposal to make a judgment. Okay, what actually to inform further your understanding of a patient. So if you have access to X-rays, MRI scans, ultrasound scans, CT scan, CAT scan, Dopplers, you name them. Okay, so these will give you some form of indication. People mention septic arthritis. Okay, comorbidities of rheumatoid arthritis, diabetes, alcoholism, IV users, ulcers that are not being treated, small cuts, small localized infection that are not addressed, lower immune system, you name them. Everything can undermine your immune system can lead to this, and these are dangerous. Okay, you can go into sepsis as well, and septic shock. Interestingly, I don't know, was it you, Joanna, who mentioned maybe the older population and UTIs and urinary tract infections? Was it you? Was it Kelsey? I can't remember. Somebody mentioned those. So in an older population, think of those factors as well. Okay, I think it was you, Kelsey, who mentioned it. Think of those factors of the patient slightly systemically unwell, start to get some joint pain, maybe a bit confused, but not all the time, a bit latent fever. So it's bringing all those things together, okay, but as well as the environment of the person they're in. Yeah, somebody wants to step in? Is that you, Kelsey?
No, I was just saying that's what I was mentioning about the older population. It's sudden changes in mood and stuff people just think, oh, it's just dementia starting, or oh, it's just grouchiness, but often it could be a serious infection. Or another thing that could contribute to it is overprescribing of certain vitamins. Yep. So you see osteoporotic women over a certain age, they start to get prescribed a lot of calcium and vitamin D, but if they're taking too much calcium and vitamin D, it could also lead to confusion and stuff. So you have to be aware of sort of what they're taking, even if it's something that seems relatively natural, like a vitamin. If they're taking too much of it, it could really alter their mood and alter like their ability to properly focus on stuff, and so it leads to confusion. It's not just dementia, it's something that's actually wrong with them.
Absolutely. So the role of medications as well is important. I mean, not something we're going to touch on today, but at some point you will be talked about medication, some side effect of medication. So I know for some, I have seen one case of a person taking too much calcium, for example, and leading to cardiac arrest. Okay, because the action potential of those cells is based on calcium and depolarization of the cell based on calcium content. So if you give them too much calcium, the cells don't depolarize, therefore the heart doesn't beat. Okay, so it's rare, but they do happen. Okay, so septic heart arthritis, just a little bit of lowdown, sudden onset of hot, swollen, tender joint, restricted range of movement, presence or absence of fever is not a reliable indicator of infected joint. Okay, red, hot, swollen. Interestingly, 11% of cases it is fatal. Okay, simply because you can go into sepsis. Okay, if delayed diagnosis or inadequate treatment, so the joint can be severely affected as well. Okay, and leave with a long-term joint pain. Okay, so important to explore those things. Okay, so site, knee, hip, ankle, and elbow. Okay, most common organism, staph, tuberculosis, salmonella. But I would say, bacterial ones. Yes, Rosie, you're raising your hand.
Yeah, I was just wondering, how could you tell the difference between rheumatoid like flare-up and the sepsis? Because it said previously that it wouldn't be their fever isn't always accompanied by it. So how do you tell?
Yeah, often, your systemic condition, okay, tend to have multi-joint, okay. You tend to have a longer history, okay. Here, septic arthritis will be a very recent history of swelling and redness, okay, restriction in joint and pain. Your more systemic rheumatoid arthritis, which is the one you're asking about, will tend to be more longer term history with some periods of remission and period of flare-ups. Okay, so the pattern is quite different. Okay, you're unlikely to have indeed fever in rheumatoid arthritis, but you may have in a septic somebody who may have a low level fever, okay, or some feeling slightly unwell, okay. You can see in 20% it is polyarthritic in nature, okay, but in rheumatoid arthritis you will tend to have the smaller joint that are infected, so your hands and your toes and your feet, as well as some of your back, your spine. Whereas the septic arthritis, we tend to find them in those, okay, knee, hip, ankle, elbow, okay. So different presentation, different history, different length, okay. And then you will have some swelling, okay, but it will not be sort of you may not have the sort of redness and heat that you will have in a septic joint, okay. You'll have some swelling, okay, but it will not be certainly as in a septic joint. A septic joint, when you also press on it, you can feel it's. I've seen it twice, I think, yeah, once or twice, where it's really there's a lot of fluid. It's exquisite. It's really hot. You can cook an egg on it, okay, and it's exquisitely tender. Whereas in rheumatoid arthritis, well, you have that tenderness. You don't have the same reporting. So different presentations, but again, having to put into the context of the patient. Okay, if you just gave a joint just like that and a picture, okay, it could be either. Okay, so it's again putting into the context of the history of the patient, age of the patient, length of time these joints have been affected, and nature. So often, whether they've traveled, whether the socioeconomic background, whether they use needles, or whether they've been they have an autoimmune an immunodeficiency in some shape or form. Does it answer the question?
Yeah, I was hoping you were going to give me something really simple, like a little test or something, but okay, that's perfect. Thank you.
It's okay. So, inflammatory arthritis, which are RA, gout, reactive arthritis, psoriatic arthritis, lupus, scleroderma, Sjögren's syndromes. Okay, so the aim is not to do a rheumatology session today. I'm certainly not the person to do that one. I think we're going to focus a little bit on rheumatoid arthritis. You've all heard of gout. I'm sure you've heard of gout. Yes, no, maybe. Yes, absolutely. Yes, psoriatic arthritis makes sense to everyone. Lupus. Yeah, scleroderma is, I think, soft tissue. What is that, Joanna, that you've just put forward?
It's a link with the differences between rheumatoid and gout and septic arthritis.
Beautiful. Thank you very much for doing that. Okay, so rheumatoid arthritis. Again, it's brief. Okay, very few people affecting women more than men. Progression is variable, unpredictable. Okay, I have seen patients very young, early onset of rheumatoid arthritis. So from the age of 15, 16, by the age of 21, he's had 2 hip replacements and 2 knee replacements, because functionally he was very, very limited. Some will declared later in life. Okay. Pain, stiffness, swelling in joint, worse in the morning, stiffness after inactivity. So other element, Rosie, about differentiating between a septic one and an RA You know, it's this sort of subjective evaluation, that stiffness, the fact that it takes about an hour and a half or an hour and a half for things to get better in the morning. With your septic arthritis, it's not going to change. With your rheumatoid arthritis, you'll feel stiff, but as you move, it's easing off a little bit. However, as soon as you settle down, sit down for an hour for lunch, you want to get up again, and it's stiff again, but then it gets a bit better as you move. Okay. So finding often symmetrical swelling, tenderness, small joints, synovitis. You can have some, because your immune system is affected, you can have some achiness, tightness, so flu-like symptom, range of movement is affected. So I will leave you to read a bit more. Joanna has kindly posted on the chat the link here, and I mean, there are plenty of resources on the internet to look at what is rheumatoid arthritis. But we look at morning stiffness of more than an hour, swelling in 3 or more joint, small bone, small joint, hand, feet and toes. You have those nodules, deformities around the hand. But keep in mind, you know, that it is a systemic disease, okay? Who was talking about the criteria for rheumatoid arthritis? Was it you, Joseph, or was it somebody else? Are these the one that you were talking about? I can't remember who mentioned that early on in the chat.
I don't think it were me.
I can't remember. Maybe
mentioning something around maybe like a questionnaire or something where it has all the common symptoms of rheumatoid arthritis and you can match them together.
Yeah. Okay. No, I think it was somebody else who mentioned the sort of criteria to determine.
I mentioned the screen dem, which was criteria to screen.
We used Jordan. Yes.
Conditions.
Is that what you were talking about?
Yeah, like inflammatory conditions. Like I know my senior body used it quite a lot. So now there's like questions. Obviously, each letter corresponds to a certain area.
Mm-hmm.
So you've got like obviously eyes, nails, Crohn's and colitis.
Oh, right. Yes, I think it's another acronym to consider all different bodily system. I'll check that. Let me just quickly search. I can't remember what it was. No, I'll try to find out. Don't worry about it. I think I know what you're talking about. Okay. Perfect. Somebody talked about red herrings earlier on, and I think it's an important one. Who was that? Who was talking about red herring? I saw it in the chat earlier on. Was it you, Rosie? I can't remember who it was.
I just put the thing in for the rheumatoid. I found it online, like the acronym. I just put that in the chat.
And you just posted it?
Yeah.
Lovely. Okay.
Yeah, I mentioned red herrings with birth control and sensitivity for women's health.
Okay. Lovely. So red herring with red flags. Okay. Thank you. Oh, that is lovely. Plenty of resources because you know more than I do. This is embarrassing. Absolutely. Screen them before you trench. Yeah. So that's skin, colitis, relatives, eye, nail, dactylitis. Yes. Is that that's what Jordan Sunny was talking about? Yes. Screen them. Yes, absolutely. The thing is, there are quite a few acronyms in healthcare to screen for either this or for a more systemic approach. But red herrings, be aware, indeed, an important phenomenon to be aware that they can be misleading clinically. Okay, so sometimes we find the things we want to find, okay, even though they're not relevant. So so it's important to to be as aware as possible, as not possible, to avoid either unnecessary investigation or delays in ultimate diagnosis. Okay, and it can, because of misattribution by the patient, the referring doctor, the treating physiotherapist. And sometimes you have patients who come in and they have a history, and it makes you wonder if there's something really untoward happening. Everything in their history suggests there's something systemically not right. Okay, so you're talking about your widespread pain system dysfunction. The patient has pain everywhere. So does it mean that they may have a systemic disease, systemic illness, systemic disorder? The weight loss, but if it's not explained properly, or you get validation for your questions, you explore that properly, and the patient will have searched on Google all the symptoms associated with the condition and will answer yes to everything you say, and therefore you think there's something really sinister going on, but nothing else, but there isn't. Okay, so and there are many conditions that complicate the clinical scenario. Be aware, take a step back, ask. I still ask questions. I will still have conversation with another physiotherapist if I need to explore a particular complex case. Okay, be safe as opposed to being sorry, and be aware of the support that you have around you. Okay, so clinical reasoning summary, and this is to focus on red flag, but I try to put it into the context of an overall evaluation, subjective evaluation of your patient. So making good clinical decision is based on making the individuality of the situation central to the process. Okay, so everyone is unique, and therefore you need to explore that person. So you need to be aware of the bigger picture of the patient problem. Okay, need to assess the importance of the combined interaction, the weighting, the sign, symptom, and integrate every aspect and elements of an individual context. Okay, so recognition that each case is unique, identify elements that are familiar and unfamiliar, and try to be open and to revise, and then in doubt, question, ask, use your safety net. Okay, we all have one. We all, even at the most experienced level, the most top level, people will still seek some form of supervision, some form of discussion to make sure they have or they've approached the patient in the right way. Okay, red flag pathway for so you have those elements. I think you know that you must have in your department certain pathway. Okay, your cardiac equina, your suspected malignancy, your VBI. We haven't talked about the VBI. Okay, your acute MSK injuries and your sort of swollen joint. Maybe it's something you've seen before. Maybe you have other pathways in your services. I encourage you to explore those as well. Just ask your senior, what are the red flag pathways for cardiac equina, for suspected malignancy, for acute MSK injury. A lot of the MSK, acute MSK, when they're serious, will turn up in A&E. But you are sometime will find that you are dealing with a full rupture Achilles tendon, okay, or an acute traumatic rotator cuff injury, particularly in a younger patient, okay, or some suspected fracture that haven't been investigated. But otherwise, they will turn up in A&E. Okay, who's ever had to deal with any of those? Out of curiosity, who's shadowed somebody who picked up one of those acute MSK injuries that were not showing up in A&E? Anyone? The few people who've had a bit more experience than the others, have you ever had to deal with any of those? quiet on all front.
I've had a lot of like safety net, cauda equina stuff, but nothing urgent.
Okay, all right. Okay, I have seen quite a few Achilles tendon ruptures, quite a few rotator cuff tears. I have seen 2 tibial plateau fractures following contact issues. I have seen some sort of traumatic brain injury following impact. So I was doing a lot of rugby work, sort of a national one in the UK and international in France. So I have seen those on the pitch, and then obviously sent to A&E with doctors, with the doctors. But in your general population, Achilles tendon, rotator cuff pathologies, some meniscal injury, some patella dislocation, for example, shoulder dislocation. Okay, so be aware of those as well. And then common sense apply here. Yes, Lewis, raise your hand.
With the rotator cuff ones, were they younger patients that needed like consideration of surgery, or was it kind of older population?
The one I saw were more older population, were more in their 40s, okay, but still needed to be assessed because they were traumatic. So so I saw 2, was it 2 years ago, about 2 years ago. One was a fall in a supermarket car park. She slipped and she landed on her shoulder. Okay, and then completely ruptured her cuff. Okay, so needed to have surgery. Interestingly, I had another one who had a traumatic cuff injury, just lifting things. Okay, I saw him, but I saw him at 3 weeks. He didn't act on it immediately. Yeah. There was still a lot of bruising, so there was bruising, and you rarely have bruising around the shoulder. Okay, shoulder, there's a lot of muscles, it's fairly deep. Here it was black and purple and yellowish. Okay, so I sent him for imaging, but interestingly, he had near full range of movement. Okay, he had some pain, but was able to move his arms. On loading, it was sore. Okay, so you would think traumatic, surgery, and then recovery. Not for him. Okay, yeah. The surgeon, when he saw him, had the investigation, did the ultrasound, then an MRI. He had a full thickness ruptured of a rotator cuff, but he had full range, full movement, minimal pain. Whereas the lady who had fallen in the car park had none of that, and she was operated on. And then operation of that, then afterwards you are for 6 to 9 weeks in a brace, okay, before you can start to move and do any activities, because the cuff has been repaired and you need to be careful with that. So it varies, but in that I would obviously send to any. If it's a young one, yes, definitely send. Interesting.
From my understanding, it was if they're younger, then obviously it needs to be acted on quite urgently in terms of repair. But if they're older and it's been kind of lingering and it's taken a while for them to get to speak to you, it's more of like an aesthetic appearance. Like if they've got full movement and strength, then they're happy to proceed. Then surgery wouldn't really be an option if it was just more aesthetically with like biceps.
Yeah, it's not, I see where you're coming. Yes, I would agree in general. Interesting. So you have the slow burners of the. We're not going to go into shoulder, but a lot of the of those one. A lot of people have asymptomatic tears, for example. Okay, I have one in my right shoulder, but they have full movement, and near full power. But I can recall a patient that I saw who had a shoulder rotator cuff tear. Okay, but was a kitchen fitter and carpenter, and fully functional, little bit of ache, okay, particularly on lifting heavy, okay, but nothing else. Was not happy with the fact that it was plateauing from a physio standpoint, and I said you can have a review with a consultant. So he had a private consultant review, who operated on him. Okay. Interestingly, he developed a frozen shoulder afterwards, and was less functional afterwards. So the consequences of his action were He went from full movement with some loss of power, but very functional, very little pain, to frozen shoulder. So surgery, frozen shoulder, loss of function, loss of range, and loss of power afterwards. I think I'm not a consultant. There's an argument for certainly for traumatic rotator cuff tear. Okay, and I think there's another argument for the non-traumatic one, slow progressive tears, where I think the outcome is, I can't remember the statistics, okay, but is not brilliant. In the young person, I would definitely have it assessed. Okay, so I know I ruptured my cuff when I was playing tennis. So I was a high-level tennis player in my teens, so playing a national level. And at age 17 or 18, I can't remember, I served, even though I had warmed up quite nicely. I served, and I felt that my racket and arm were in the net. And actually, my racket was in the net, but my arm was dangling down on my side. Okay, but it was 1987 or 88, and cuff repair didn't exist. Okay, so my tennis career ended abruptly. And I ended up with I think every time now I have a throw, or I play tennis, I've got this chronic issue. I know I have a tear. I know I have a full thickness tear because I had scans done on it. But I was offered surgery, and I say, what's the point? Okay, I'm not going to be a professional baseball player or tennis player or thrower. Okay, there's no need. Okay, I'm fully functional. I can still serve. I can still do some tennis. I just have to warm up a lot longer, and it's sore for 2-3 days afterwards. Okay, so it's the balance. So the immediate management nowadays for somebody like me at the time was certainly been surgery. Okay, with good rehabilitation and certainly very good outcome. At my age, I think surgery now at 50 plus, pointless. Okay.
Thank you for that. Cheers.
No problem at all. We will explore shoulder in the as of when you start the ADP, the Accelerated Development Program, in January. So, what if I suspect something sinister? Keep calm, be zen. You're Buddha. No, keep calm. No panic. Certainly, don't panic your patient. I've had a lot of ask injuries from working in rugby. Yes, Cheryl, I'm sure you've had. Speak with your team leader, your buddy, triage clinician if uncertain, need reassurance, explain in an empathic, calm manner why they need to see the GP, go to any, because it's going to be your responsibility to do that, okay? And reflect on it. I think you need to learn a lot from this. I still learn from it. I will certainly still be sometimes hesitant to make certain calls, okay? Because I don't necessarily have all the experience that others would have had, okay? You may need to do a due diligence, ring the GP, ring the A&E department. I remember doing this for cardiac symptoms. I was just almost told to go away by the person I called, asking for the registrar, even though this was the pathway that needed to be followed. Okay, so clearly communication between with the hospital and A&E department is not always the easiest to do, but it needs to be done. At least you have done your due diligence. You can record it. You can, and then if there's any issues, you have evidence that you've done what needs to be done, and you follow the pathway. Okay, so check your pathways for your serious pathologies, not just cardiac coronary, but any other that we've discussed above. So malignancy, cervical injury, acute MSK, sepsis, or other that you may see in your assessment. So what is your index of suspicion? Okay, remember, this is what we're talking about. Okay, over medicalization and investigation can cause the patient a great deal of distress. Okay, so try to be as aware as possible of, yes, this is a red flag, or it is maybe a red flag, or it isn't a red flag. Okay, and in that, use your support, use your team leaders, use the senior physios in your department. And things are not always what they seem initially, indeed. And how many red flags or red herring are present. Okay, so it's having the reflection even during the consultation, and then just even pause a little bit and just think about what you're hearing and what information you're gathering, to make sense of it and to decide, yes, okay, I need to act on it, or oh, I need to speak to somebody, or no, I'm quite happy actually, this is not a red flag. Okay, there you go. 10 to 12, we've got 8 minutes for questions, concerns. So we sort of stop to on red flags. Okay, as I said, I've tried to integrate this within a more global and general approach to evaluation, subjective evaluation, if we're going to use the term. Okay, but try to keep it as simple as possible, while knowing what you're asking for and what you're trying to identify. Okay, sometimes some patients can be overwhelming, particularly when they present with multiple pathologies. If they present with a lot of psychosocial factors and anxieties, depression, they've looked on Google and they're starting to panic about their condition. Okay, be aware of some of the signs and symptoms for those serious pathologies, but keep in mind that patient may have those and not present with anything at all. Okay, but some, vague and unspecific symptoms. Okay, so just trying to keep an open mind as much as possible, and that will come with exposure. That will come with discussing case studies with your peers, reflecting on what you've seen, on the mistakes, but also on the good things that you've done and identified. Okay, and building that, so what we call experiential learning. That ability to progress and grow based on what you see, what you do, and the exchanges that you have with your peers. Okay. Any burning question? Any? I know it's certainly quite a lot to digest for you guys. Okay. Hope nobody is panicking. Any worries? Anything that I can address at this stage?
I'd say no worries for me. I'm not talking for everyone, but I really enjoyed the mini cases that you give as examples. I feel like talking about red flags is one thing, but when you give examples of like the woman with shoulder pain, which is drink alcohol, that's not something that we would think of unless we've seen it. So I enjoy hearing those.
I don't think anybody saw it anyway.
No, but I think having those case studies and hearing your experience with the red flags is helpful to put it more into perspective rather than just checking list of questions to ask.
Absolutely, and I think what is important is to look at also when we talk red flag. I had a patient in occupational health. We came in with a 4-week history of Achilles tendon pain, and his Achilles tendon was ruptured, and it had been missed by the doctor, and the doctor had sent him away with painkillers. Okay, and interestingly, this is a gentleman who was 6'4", from Lithuania, well hard, not listening to himself much. Pain is pain. You have pain. I deal with it. But he thought there was something a bit wrong because he couldn't really push off from his foot. But that Achilles tendon rupture was a red flag. Okay, it was an acute MSK injury that needed to be addressed. So 4 weeks later, I had to send him to A&E for him to be fitted with a boot with his foot in plantar flexion in order to allow for the tendon to approximate with the other bit that had gone off and starting to retract. So he had a good outcome, but it took him 9 months to recover from this. So it's not always the sinister ones. It's also the ones that have a significant impact on a patient's life and well-being, quality of life. And remembering what we talked about at the beginning, that yellow flags can be, as far as I'm concerned, red flags. That other issues can become serious concern for our patients' health and well-being. And often we have red flags, we consider it as too narrowly, these are the sinister pathologies, okay? And yes, they must be addressed. But I think is having this step back, this broad approach of a patient, and to really identify things that could become red flags. Your suicidal thought, your severe anxiety, your severe depression, you're putting others at risk, putting yourself at risk. For example, social factors, financial issues that could spiral out of control, particularly in this era where people are losing their jobs, people are exercising less, they're not consulting their GPs anymore, not as much. You know, people not going to A&E, having delayed on surgeries or on symptom presentation, because it's harder and harder to access a health professional. So it's being aware of the context, okay? Because I strongly suspect that a lot of patients are not acting on certain symptoms as well. And if you have them at the end of the phone, you need to be aware of that. So even more alert to your patient history and specific variables. Happy with all this? Any other? I'm glad you like this sort of a little input. I've tried, compared to last week, I've tried to ask you guys questions for you to step in, to come on the mic, to give us your views and your understanding, as opposed to me going through the whole presentation without interruption and making it boring. I hope you've liked a different format, less didactic and a bit more reflective. Thank you, Joanna. Thank you, Kim. I don't think we got anything this afternoon, have we? I don't think I've got nothing in my diary this afternoon.
We've got something in our calendar. Hang on. Lumbar, spine, and lower limb.
Okay, but that's not me who's doing this, is it?
No. Yeah, it doesn't say who it is, but yeah, that's what we've got at 1 o'clock.
At 1 o'clock. Okay.
Let me just check. Yeah, 1 till 4.
1 to 4. I may ask who that is. Is it Rob Tyers? Fantastic. I'm going to ask Rob to send me an invite for me to join on it, or can somebody forward to me the invite so that I can join in? So what you do is you click on your Outlook diary or something like that, click on the invite and send it to me, so I can receive this. Somebody happy to do that for me? Perfect. Because I haven't received that link. It'll be interesting for me to listen to how Rob delivers that as well. Okay. Well, if that's all for today, everyone, thank you very much for your time. Okay. Enjoy this afternoon session, and I'll certainly speak to you next week. And thank you very much for all your participation and all your input.
Thank you.
Thank you.
You're welcome. Have a good lunch.
Bye.
Bye.
Bye.